Hi everyone, I am back with a new video, and today is a perfect time to talk about visual problems. So let's see what I have for today. So there are several visual problems that we're going to be talking about, and number one, it would be glaucoma. Glaucoma is, think about it as the hypertension of the eye. So there's a buildup of pressure and that increases intraocular pressure. And so I basically kind of say that it's like hypertension because we got buildup of pressure. Now, when we have this buildup of pressure, it sort of kind of can pinch or damage your optic nerve. And so that leads to peripheral vision lost. And so now this is common in African Americans, people with advanced age, like elders, and also individuals that don't really check their eye regularly. It's the second most common cause of vision loss. And so in order to really define and for you to understand what kind of causes this buildup of pressure or intraocular pressure, it has to do with these drains that we have in our eye, that there's an aqueous humor or jelly substance that we have there. So when those channels get blocked or occluded, then the buildup of pressure happens. And so this is a little bit of kind of where it is in the eye. It is in the front of the eye near the pupil. And so if these kind of like in your picture here, if the channels or that opening gets occluded, then we start having issues. And the liquid substance, kind of jelly substance, is called the aqueous humor. So there are two types. One is chronic and one is acute. The open angle, it's the chronic one, is the most common. And so the release or the outflow of this liquid substance that I'm talking to you about basically gets affected because it gets stuck or clotted, almost like your drains. Whenever they get clogged with, I don't know, debris or maybe us women hair, your water can drain from your tub. And so that's a way of kind of seeing it. And so now some of the manifestations for this is gradual but slow vision loss that does not reflect any pain on the patient or pressure. You start losing this kind of peripheral, kind of to the right and to the left, visual fields, and then the individual just sees the middle only. So that's what we call it tunnel vision. Now, there is the acute one, which is the angle closure. And here you have complete reduction or blockage due to the dilation of your pupil. And so this one is a medical emergency and it happens very sudden. It causes excruciating pain in or around the eye. It can cause nausea and vomiting due to the pain. And then individuals, the clients, have these color halos or blurry vision and eye redness, just like the picture here. We really can diagnose it with just ophthalmologist visit, them checking your intraocular pressure, which should be normally between 10 and 21, and then having those peripheral and central vision measurements. So, but all these are done at your ophthalmologist. Now, there are different ways we can treat it depending on which one it is. So, the medical emergency, we just have to intervene very quickly before you lose vision. But the chronic one, the open angle, we can give them eye drops that basically either decrease the production of this aqueous humor, which is that liquid substance, or decrease the intraocular pressure. So I kind of separate them. They're B adrenergic blockers. They end in law because they're better adrenergic blockers. Um, and so the names are kind of long and kind of hard to pronounce, but I listed them here. You can read them. However, they're contraindicated in asthma and COPD patient or patients that have heart failure or decreased heart rate because it can have this reduction of not systemically and severe, but it can affect a little bit of that heart rate. Another classification is adrenergic agonist, and basically they end in dined or end. Now, these increase the heart rate and increase your blood pressure. So we have to be careful with, like hypertensive patients or patients that have, tachycardia, etc. Um, the drugs are not the treatment. It does not cure completely glaucoma. It's part of the treatment. And if you stop your drops, then you can have intraocular pressure increase severely. So very important to kind of educate your clients on, hey, we got to continue these drops, but they don't cure it. It just controls basically that pressure. There are other medications, the cholinergic agents or miotics. These cause the contraction of the pupil and enhance that flow of the liquid. And then you have your anhydrase inhibitors, and also they decrease the production of the aqueous humor, but they're contraindicated to take it with aspirin. There is a laser procedure that is called the argon laser trabeculoplasty. It's fairly non-invasive. It's usually an outpatient procedure, and basically it lowers the intraocular pressure, or at least it tries to lower the intraocular pressure when medications have failed. The goal is for basically to laser that area where the outflow of the liquid comes out, kind of creating some scars, and that the scars kind of makes contraction of that meshwork, which then it opens the outflow channel. It kind of creates this, it pulls it back by contracting, and it opens up the channel. After the procedure, patients get steroids, and they follow up with the physician 1 and 4 and 6 weeks after procedure to monitor that intraocular pressure. So intraocular pressure is very important after a procedure or eye surgery, just to make sure that everything is going well. Now, for the angle close, the acute one, the medical emergency, it needs different treatments like miotics and other medications as well as laser, but they're going to basically intervene right away, because they know that you can basically lead to vision loss since it puts pressure on that optic nerve. Now, the next visual problem is cataracts. Cataracts is whenever the lens that you have inside your eye gets old and it becomes opaque and almost looks like, think about a spider. Well, I don't want to say spider web, but think about that old glass, or, oh yeah, I know what it looks like. When you have an older vehicle and it creates on the front lights of the vehicle, it creates like this kind of shadow and opaque lights. And it has almost like a whitish look or yellowish look to the light. Um, well, that's kind of the closest thing that I could think about cataracts. Well, but it basically happens in our lens on our eyes. And so it could happen in one or two of the eyes, so unilateral or bilaterally. The risk factor is just simply age, smoking, alcohol, sometimes being diabetic, or use of steroids, or if you've had trauma before. It's actually, if it's that bad, you can actually see it with just your naked eye by looking at someone's pupil. You can see that their pupil is whitish, just like this picture here. I'll show you a new picture. So normally, you have your regular color pupil, kind of dark. And so then you have that whitish look to it. And so whenever you have that fuzzy, kind of opaque area on the lens, people can't really see. And so your vision becomes distorted. We diagnose it by, again, examination through your ophthalmologist. And sometimes you almost don't even need an ophthalmologist. You can actually see her by just looking at the individual's pupil. So you have this decrease of vision. Imagine it's blurry, right? The lens is opaque. You cannot see clear anymore. Your pupil becomes white. You have this glare and abnormal color perception. There is really only one cure, and the only cure for it is cataract surgery, removing that lens and putting a artificial one. However, meanwhile, before you get cataract surgery, you can sort of treat it with just modifications. Like, example, maybe increasing your eyeglass prescription, making it stronger. You can use like a magnifying glass or reading glasses. You can adjust the light. You can basically, instead of driving at night where everything is dark and that glare and blurriness is worse, you can drive during the day. But really here, the cure or the treatment of choice will be cataract surgery. Now, cataract surgery is kind of outpatient, local anesthetic. They give you a little bit of drops to dilate your pupils and some NSAIDs prior to surgery. And then they just basically remove, either by shattering the glass and sucking it out, or just removing the glass um, and just replacing it. After the surgery, they give you antibiotics and steroids to kind of heal the cornea. And they tell you not to increase your chances of increased intraocular pressure. So any activities that will increase intraocular pressure are prohibited. And so what are those activities? Well, anything that kind of, think about intraocular pressure or build of an intraocular pressure as anything that kind of makes your head pop. So bending, if you bend down, you kind of feel that pressure here in your head. If you're coughing, if you're sneezing, if you're lifting, if you pinch your nose and you blow, all of that kind of makes your head pop in a way, or you feel like a pressure in your head. Well, the same thing. Another one here is also bearing down, like if you're going to have a bowel movement too. Some people strain and you're like, so that increases intraocular pressure. And also because your cornea is cut, they'll protect your eye with either eye patch or these
very beautiful glasses just to make sure that you don't scratch or cause any infections at night while it heals. So here's a easy to read. And then the next visual problem is retinal detachment. Retinal detachment is this layer that we have in the back of the eye that it's the life of the eye in a way. It provides um, blood, oxygen, nutrients, and if it detaches or tears, creates a tear, then it leads to blindness. And so think about the retina as the life of the eye. And if you don't have that, you unplug it, boom, no oxygen, no nutrients, no life. So you lose your vision. So it can lead to permanent blindness. Sorry about that, something fell. It can lead to permanent blindness if not treated promptly. The risk factors are cataract surgery, nearsightedness, so people that cannot see from far have a high risk. Also, age and trauma or family history. You diagnose it the same way. You can do acuity tests, a vision test, and visiting your ophthalmologist. And your clients manifest in this particular way. They have this sudden or gradual increase in the number of floaters. So when you're looking at something, you see like little things floating, and those are just the blood from the tear. You can also see cobwebs or spots that float in the vision field. And that's why when I said earlier about cataracts like a spider web, I retract from that because retinal detachment, it has this cobweb. So I didn't want you to get confused. Anyways, it can manifest as well with flashes in the eye or in the light, like things are flashing. And if it detaches completely, you can see almost like a curtain that falls over that field of vision. Now, it's painless, and that curtain, it's inverted. So if you see it on the top, it happened on the bottom, and vice versa. Retinal detachment is a medical emergency, and the treatment for it is surgery. You have to fix it. You have to kind of go back and fix a tear, or um, stitch or buckle, which we're going to learn soon, that retina back into place. So, a couple of procedures that can happen. So, there's laser photocoagulation and cryopexy. Both of these methods prevent fluid. It's usually done when there's a tear. They both of these like prevent fluid from kind of getting into the middle of the eye after it passes through the tear. And so if that fluid gets under the retina, then the retina detaches. So it basically prevents from fluid getting underneath it. And I'll show you a picture here shortly. The only difference between them two is that laser is done with this like intense beam that kind of burns, and cryopexy is basically with a freezing substance, and so it creates a scar over the retinal tear, and then that prevents the fluid from getting under the retina. Um, Here's sort of kind of how it looks. So you have, a small tear, you snap it with either the laser photocoagulation, making those small tears, it contracts and then it pulls back in a way. And so that prevents stuff from getting underneath and lifting the retina. The next is sclera buckling, and that's what earlier I said, it's kind of stitches or buckle it. Think about sclera buckling as a belt you put around your pants so they don't fall. Okay, so it's kind of the same thing. It has the surgeon sutures this band against the sclera, pressing on the eye wall and keeping the separated area together and allowing that retinal to reattach to the eye. Usually it's an outpatient procedure, and in most times it's done with one of these other procedures, kind of like in combination with one of these. The pneumatic retinopexy, they inject this kind of bubble of air or gas of air in the middle of the eye, kind of pushing outwards the retina, and then they buckle it until it heals. I think a picture is worth more, it's better than, a bunch of words here. So let me show you a picture. So here's the sclera buckling. You have this band around, and so it kind of touches the retina and allowing it to heal and reattach back up. Or you can create this bubble inside the eye, bringing and pushing the retina back to the wall, and then again buckling it. So most of the times these two are done together. The vitrectomy is just the removal of, we have a jelly substance in the middle of the eye. And so that one is done to relieve the traction of the retina. Okay, so again, they could do all these sort of three procedures at the same time, or by the vitrectomy and the buckling or whatnot. Your ophthalmologist will decide which one you need. Now, post-operative care. So a couple of things important here. The prognosis varies depending on how complicated the care is. Most of the times after a procedure or eye procedure, like retinal detachment, you're going to be in a special position in bed. Usually it's facing down. And the reason for that is so, again, kind of gravity. If I'm facing down, everything is going to go up into the eye, and so it pushes the retina back up, especially if they put that bubble of gas and whatnot. You will get several medications, intraocular medications like eye drops, such as antibiotics, anti-inflammatories, steroids, analgesics, and dilation of the pupil. You will have restrictions on the activities you can do. For example, all those that increase intraocular pressure. So you might have people on laxatives or fibers to make sure that they're not straining when they have to go to the bathroom. Or if you have someone with nausea and vomiting, you want to treat it right away. Of course, not lifting anything, not coughing. And then you monitor and report any hemorrhage or sudden eye pain. The sudden eye pain is related to intraocular pressure. So the risk of having intraocular pressure after eye surgery is high. And so if you have someone suddenly reporting, I have eye pain, you might want to check their intraocular pressure or notify the physician, because the chances of them having intraocular pressure higher than what it should is high. Also, remember safety. There are risks for falls, especially because their vision might be off. And so all these teaching points are on page 365, and they're all educated to the client. All right, well, those are the visual problems that we are covering in adult. Again, my reference are always the book, and I obtain my images from Google or the book, and I'll see you in the next video. Bye-bye.